cell-free fetal DNA. And typically, the cell-free fetal DNA is done at 10 weeks onwards. Now you might ask, why not 7 weeks? Why not 7 weeks? The answer to that question might be that, very difficult, there's nothing, no nuchal fold detection at 7 weeks. Okay, it's not even a little human form. But the blood takes the cell-free fetal DNA. So ideally it's done at 10 weeks, and sometimes, like you might defer because at 10 weeks, the only thing that's required by these tests is the CRL. The CRL depending on the last menstrual period, or the CRL depending on the ultrasound. So you can defer your first trimester scanning until 12-13 weeks, when you get a broader picture of the anomalies. Triple test and quad, these are done 15 to 20 weeks. And CVS starts at 10 weeks. Amniocentesis starts at 15 weeks. And again, my colleague will be able to tell you the details when I refer my patient to him. Okay, now, all the biomarkers I'll touch, because when we talk about high-end NIPT, we forget about these. But these are equally important in the life of an obstetrician and the patient. So characteristic advantages, disadvantages of common screening tests for an employee. Now, if you see, that the top is the risk factor, biomarker, gestational age. At the age of 35 and more, the sensitivity to these markers, and I'll tell you the markers, what are the markers, is about 30%. Okay, 5% screen positive, specificity is in 1 in 100. Detection rate is 30 to 50, so it's very, very little, and false positive rate is high, 48 to 55%, if you take the age only. Now, if you go for the first trimester assessment, which includes the blood test, HCG and PAP, and the fetal ultrasound for the NT. This is done at 11 to 14 weeks. Sensitivity goes up 87 to 89. 5 screen positive. Specificity is 1 in 25. So it's not, the specificity is low. The detection rate is good, 79 to 90%, but then we have a false positive rate of 5 to 9%. That means that you might subject that 5 to 9% to an invasive procedure of CVS or amniocentesis. So this is the second trimester screen, which is the same, it doesn't give much improvement on the detection or on the false positive rate. So now this one, this is what I'm talking about, and the rest of my lecture will be focused on this dynamic test. So this is cell-free DNA, and it is done 10 weeks onwards until term. Sensitivity is 92.6 to 100%. Specific 97 that is 98% to nearly 100%. And you see most of the people, that's researchers that have done those things, they were very impressed, and to be honest, in fact, some of them even call it a non-invasive prenatal diagnosis, not non-invasive screening test. Okay, that's why you don't see any detection rates, you don't see anything. So this is the person I've told you about, Dennis Liu. I met him in Singapore. I think now he's about 46. When he did all his discovery, he was about 36, 37-year-old. He graduated from Cambridge, did PhD in chemical pathology from University the Oxford. Then he went to the US to broaden his vision on what he wanted. Because we all know that in the US, you have a wider field of anything you want to do, so long you want to do and prove it. So, and then he got the first ever Life Science Prize, which is equivalent to the Nobel Prize for developing tests for Down syndrome in fetus in China. He used the next, I'll tell you, I'll just read this. He used the next generation sequencing, which is called MPSS, and in 2012, other researchers built on further work by Wu to sequence the entire genome of a fetus non-invasively. So when they do that, you get many other disorders, right? Like Rh phenotype, like thalassemia carriers, and many others. And in recent days, when he showed his paper in the Royal College in Singapore, he is working on cancer cell-free DNA of cancer cells in the fetus. But then he says that is it right that I'm doing, that telling the parents 40 years before that your child might develop some cancer. So is it ethical? So there's a big ethical issue. Okay, so, next generation NIPT using cell-free DNA. They have two types of lab processing. One is the massively parallel shotgun sequencing and counting. This one is extensive. They count the total genome. If you say for T21 or T13 or T18, which are the common ones, right? And it is time consuming, but luckily they produce the same report in 2 weeks' time. And then the second one is the targeting sequencing, which is they target the specific genomes. Specific means T21, T18, T13, or whatever, T7, T16, okay? They target those genomes, okay? And if there is possibility of microdeletion, they target, genomes that can have the microdeleted part of the genes. Okay, so they compare the two. Both can be done. Okay, they reported as positive or negative, and CQNM there are 3 laboratories that is very popular and renowned, and of course they have their own laboratory in Singapore and Taiwan and Hong Kong. So the chromosome tested with the MPSS 21, 18, 13, XX, XY, XXY, XSY, the sex chromosome and employee. Okay, and the very nature also does the same. And Riosa does only 21, 18, 13. With the targeting sequencing, they are able to do multi-fetal gestation, that is multiple pregnancy. Most probably first by identifying the cell-free DNA of the fetus in the maternal blood, and then do the sequencing. But it might be easier if it is a monozygotic twin, because they will be sharing the same DNA, okay? So if you find a DNA and many DNAs having the same, and you have been reported that this is, because at 10 weeks you can see whether it's dichorionic or diamniotic, and that takes it there. So they are able, but until now it is not validated. They also accept egg donors and surrogates, okay? And their turnaround time is the same as the MPSS. They're all between 8 to 10 days. And in our center, we have our accounts. So we get the results on our screens within 7 to 10 days. Okay? Sometimes, of course, it takes longer, and I will explain to you why. So what does this test, what we are looking for? As I said, we are looking for an autosomal aneuploidy, which is T21, 13, 18, and many others. Sex chromosome aneuploidy, like Klinefelter's, Turner syndrome, XO. Then microdeletions, which is the absence of small portion of genetic material in a chromosome. And then fetal sex determination. In our center, that is one of the charts of though there are a lot of ethical issues might be in India, where they're not allowed to know the fetal sex, okay? But in our center, that's an extra charm. People come to do it, and they will always request, most of the time, the sex determination. Okay, now this is the American College and American College of Medical Genetics screening pathway. As I said, that we don't leave anything behind, run to this high tech. The first trimester risk assessment, the age, history, and the two tests that we do is the ultrasound, see the nuchal fold, and the double test, which takes HCG and PAP. So if this is, then they divide into three groups. Very high risk, okay? Here I'll tell you what they do. Then this one is intermediate risk, okay? This one, we get. But high risk, we get, but not as often as this group. And this is the low risk. So if somebody is high risk, very high risk, the patient, the lady will go to the invasive test. Of course, there is pre-counseling and all the things, what you do, what you test for, what happens post-test, everything, right? Then only then, because you don't go for, that is CFF DNA, okay, testing. And then if it's positive, they are reported as positive or negative, detected or non-detected. Because this is like Harmony detects as positive or negative, and Varinator refers to as detected or non-detected. So if it's non-detected, goes to the low risk group, and then go for no further testing, reassurance, everything, counseling. Okay, it's just go away for a low risk pregnancy. But this one, the high risk, obviously will go for NIPT positive, becomes a high risk, goes to the MU. So this goes to the MU, and this goes to the MU or CPS. Okay? Now, counseling patients about their options. What should you counsel? Patient might say even, really, I don't want to counsel. Some patients, they don't even want the double test to be done, or they decline even fetal nuclear fold. So counseling is very, very important because it's her body and her baby. So counseling regarding limitations of the test. I'll tell you what, later, the next slide will tell that. And counseling that NIPT assesses risk of chromosomal and genetic disorder. What you do then? Then cell-free DNA is a screening test. Until now, we are not able to tell people that this is a diagnostic test. Because if it's positive, it has to have an invasive test which has a detection rate of 98 or even 99%. It is imperative, so diagnostic test is recommended if, as I said, it is imperative that practicing OBGYN or other healthcare professionals has a firm knowledge of benefits, limitations, and risk of offering a specific genetic test, as well as the importance of appropriate post-test counseling. So we have to know what we are talking to the lady in front of me, counseling, what it is, what it will bring to you. Are you ready to accept, an abnormal fetus? What do you do? Is it that just you want to know for peace of mind, and then your other siblings, you tell them that this baby is coming, is a little different from you guys. So there's no bullying, there's no, dismay. So you carry on, or you go for termination. So these two are the most important thing for this. Counseling. Then we go to indication for considering use of cell-free DNA analysis for fetal aneuploidy. This is from the American College and the American College of Medical Geneticists, and I'm sure this is also now addressing the Royal College. Maternal, any mother above 35 and above at delivery. You see, sometimes we make mistake. How old are you? 34. 34 plus? Yes, 34 plus. So what we have to know when she delivers, if that time she is 35, then she falls in this position. And fetal ultrasonographic findings indicating an increased risk of aneuploidy. We know the increased nuchal fold. We know that the nose, the characteristic of the heart defect, then personal or family history of a prior pregnancy with a trisomy. Okay, there can be family history. I have currently a patient. Her health event had 4 and 1 is just recurrent 2 or 3 days ago, and she had her investigation in the US, and her husband has a balanced translocation 7 and 13. So that was a reason for her miscarriage. She was advised strongly against going into spontaneous conception, but she can go for PGD, Prenatal Diagnosis, and IUGR. Okay, so these are so important. I've seen the lady, in fact, yesterday. But then, this is for the woman 35 and over, right? But what happens to this little group? Because we know that most of the Down syndrome, most of the women pregnant are younger women, right? But the individual risk of a woman is when they're older. So most of the Down syndromes are coming from younger women, okay? So is there a way of doing something, without any history, family history or past history or anything, okay? So, but now I'm sure I'll be able to change my thoughts. Like when I see that anybody having miscarriages, no live births, or say 3, 4, 5, 6, I think that these women should be, whatever the age, whatever, these women should be offered the high-end NIPT. So how does prenatal screening differ in multi-fetal gestation? But I've shown you in my previous slide that there is one company using the target sequencing that they are ready to accept multiple gestation, but twins only, not triplets, not any higher order pregnancies. So, but until then, we have to say the accuracy of screening for aneuploid is limited in multiple gestation. With any method based on maternal blood, that's serum analysis or DNA, only a single composite result for the entire gestation is provided, with no ability to distinguish the differential risk between fetuses. The data regarding performance of cell-free DNA screening in gestation is also limited. Although preliminary findings suggest that this screening is accurate, larger prospective studies are required to establish a firm recommendation. Okay, this is how our lab draws the blood. So this is a woman, okay, the blood. It's about 10 or 20 ml of blood. This is for the DNA extraction. Then it goes to the lab for to the library construction, sequencing, and analysis. So this is the main part. Okay? Can error happen here? It can, right? That's why we say even if a center says 99.9%, there might be an error. Okay? Then it goes to the physician, like I'm sitting on my desk and looking at the computer. And then I find the test. We call the lady. We call them as soon as possible, as soon as we see the test, because it is a tremendous amount of burden on a woman who's doing this, and you have to wait for 7 to 10 days. And here is the counseling. Obviously, if it is negative, they are smiling, thanking, and going home. If it's positive, then obviously has to be referred to for invasive procedure. So as I said previously, some of them referred to as low risk. That means unlikely the pregnancy is affected. High risk, likely the pregnancy at risk of an aneuploidy. And some of them report aneuploidy not detected, aneuploidy detected. And another very important, notification is the test uninterpretable or indeterminate. In this group of patients, don't take it for granted that there's something wrong with the blood sample or resending. No, resending will take more time. Here you need to do further genetic counseling, get the history, see the age, past history, do the karyotyping, and offer comprehensive sonographic evaluation. Because as I said, in ultrasound also there are biomarkers in the heart, echogenic bowel, echogenic shadow in the heart, short femur. I mean, these are the things that you're looking for. And a diagnostic testing, which is amnio or CPS. Some might say that there's no result, and we get, especially in hot summer, when the blood gets hemolyzed before they reach the center. Then they come back, but now they have developed. Last year we had suffered a lot, but then now they developed, ice packs that they are kept in the ice pack for before they are transported, and then obviously the DHL, maybe in the first class, maybe goes to US or to the UK. So who can have the NIPT? I've told you the indications. The patient has to be 10 weeks pregnant and more. The patient must have been counseled. Singleton or twin pregnancy. Let's now just keep on the singleton area, not this one. This one we need more studies. Then the presence of the prenatal screen is unsuitable if the patient has cancer, herself she's a trisomy, blood transfusion in the past 12 months, undergone stem cell therapy or immunotherapy, or received an organ transplant. So these are the patients that during counseling we find out and we have to say no to this group of patients. I didn't get too many of the studies, but I want to touch base of this test. This is one of the tests which was, I think Nicolaides is here also somewhere, yes. This was he and his group did this one, and they found that trisomy 21, as I've showed you in the slide before, 99.3%, specificity is 99.8, age 25 years, the positive predicted value is 33. And for an older woman, age 40, it is 87. So that hits the mark. And with the 33%, I still feel that is a bit high. For trisomy 18, similar figures. With age, it increases the positive predictive value. Then sex chromosomes, you get it in the region of 100% specificity, and the detection rate must be 100%. Some actually in our